If you're in midlife and wondering where the hell your desire went or how to get it back and make it hotter than ever, you just found your show. I am Dr. Stacy, clinical sexologist and certified sex coach, and this is the Purple Passion Project, the intimacy and sex podcast for midlife and beyond. Just real spicy conversations about desire, intimacy, and pleasure that will change the way you think about your sex life forever. Let's do it. Hi, I'm Dr. Stacy, and this episode is brought to you by my pleasure playbook called Desire with a Diagnosis. Most people think that this guide is only about physical conditions, but a huge chunk of it is about medications and how they change your body's response to arousal and pleasure, which is exactly where we're headed to today. So if your brain works a little differently, or if you're on medication that's changed how your body responds, this guide was written for you as well. So grab it at drstacyfriedman.com. The link will be in the show notes. And speaking of brains doing their thing, that is exactly what we're getting into today. So welcome to the Purple Passion Project, where we talk about sex, intimacy, and all of the deliciously naughty things that you have been thinking about, but no one gave you permission to say out loud. Midlife is not where your sex life slows down. It is when it should be hotter than ever. So buckle up and let's talk about the brain side of sex, such as ADHD, autism, sensory processing, depression, anxiety, and all the medications that treat everything. And none of this gets discussed enough. And when it does, it usually gets treated like an afterthought that is tacked on to the end of a mental health conversation instead of a legitimate topic on its own, because it affects so many people. And so your brain actually runs the show when it comes to desire and arousal and connection. So if your brain works differently or is being supported by medication, your sex life is going to work differently as well. That is not a deficiency. That's just information. And today we are going to figure it out. Let's start with the framing for today, because if you only remember one thing, let it be this. A brain that works differently is not a barrier to a great sex life. It might mean that you need different tools than the person next to you, but different does not mean less. And so much of standard sex advice assumes a brain that is not managing constant sensory input, and it doesn't need extra effort to initiate a conversation, or it isn't affected by medication that changes brain chemistry directly. That is not most brains. That is a narrow little slivered slice of brains that got marketed as the default for way too long. We are all in the brain somewhere having some type of dysfunction, I think. But anyway, here is a concept that's going to come up again and again today. Executive function. That is the mental system that's responsible for starting tasks, switching between them, managing time, and regulating emotion. Executive function gets taxed by ADHD, by autism, by depression, by anxiety, and by many of the medications used to treat them. It requires noticing that you want something, deciding to act on it, communicating that want, and following through on it. And when that system is already stretched thin, managing everything else in a day, sex is often the first thing that gets dropped. Not because desire is gone, but because the mental bandwidth to act on it is not there. And that is a critical distinction. So let's sit with that for a second. Low initiation is not the same thing as low desire. You can want something intensely and yet still not have the executive bandwidth to start it up. And that gap usually gets misread, actually pretty often, by both the person experiencing it and their partner as disinterest. And it's usually not disinterest, it's usually just a bandwidth problem. So for example, if you're autistic or you've spent your whole life managing ADHD, squirrel, in places or spaces that were not built for you, you've probably spent an enormous amount of energy masking, suppressing stims, forcing eye contact, performing small tasks that don't come naturally just to get through an ordinary day. And by the time that intimacy is even on the table, there's often nothing left in your tank. And that's not a desire problem. That's just an energy budget problem. And so the fix is not more willpower. How can I get this? I need this. I need this. It's better budgeting. It's better figuring out how to get that bank to be filled, the tank to be filled. And so here's what this actually looks like in practice. So you want to notice when parts of your day or week drain you the most, and whether it be like a full day of meetings, sensory heavy environments, social masking, and protecting time near your highest capacity windows for intimacy, the same way that you would protect time for anything else that matters. So lower the bar for what counts as connection on the days that you feel just like shit, that you feel depleted, that you just don't have it in you. It could be something like a 5-minute check-in, a specific kind of touch, or even just lying together without any expectations of it going further. You can look at intimacy as a way to connect rather than this 2-hour production to count for both of you. And so that on those lower days can be very, very helpful. So you have ADHD, depression, and desire. They all run through the same neurochemical highway, the dopamine. And so ADHD brains are frequently dopamine seeking. That is part of why novelty and hyperfocus feels so good and routine feels so hard to start. Depression often involves the opposite problem. It's a dopamine system that is underactive across the board, which is probably why nothing feels rewarding to pursue. Sex just is completely not anything that you would think of being rewarding when you were in that depressive state. And so understanding that both patterns run through the same system, that explains why just sometimes generic advice to just get in the mood can fail completely for both of these people. You're not managing a mood, you're managing a chemical system that responds to specific conditions. And once you know that, you can work with it instead of forcing your way through it and doing things that you don't have desire for. So you have emotional regulation and executive function. They're very close together, and both of them get taxed by ADHD, autism, depression, and anxiety alike. Sex requires a baseline of emotional regulation to feel good. And so you need to be able to tolerate vulnerability, handle an unexpected reaction from your partner, and be able to stay present through discomfort without spiraling out of control. And so when regulation is already stretched thin from managing the rest of your day, intimacy can feel like just one more demand on a system that's already kaput. It's already at capacity. And this is exactly why the timing of your intimacy matters as much as the desire itself. So trying to initiate right after a dysregulating day, that sets you up to struggle, not because you don't want connection, but because your nervous system does not have the reserves left to be able to regulate it. If you've noticed that intimacy feels far more available on the weekends than on a regular Tuesday, that's not a coincidence. And it's not about attraction dipping. It's masking. It's that constant, often unconscious effort to appear more neurotypical than you actually are. And it's exhausting. It's a very exhausting way to be able to live your daily life, because that compounds across of a week's time. And so by Friday, the reserves that would normally support desire have usually been spent elsewhere. And this idea is usually worth explaining to a partner who might otherwise interpret weekday disinterest as something that is wrong between the two of you specifically, when it's actually about just the day that you already had. And that can be a big helpful explanation. And so there's also a specific and common experience worth addressing directly as well. Wanting sex and simultaneously not having the capacity to pursue it in the same moment, they can live in the same space. That is not a contradiction, and it's not you being difficult. Desire and executive capacity are two separate systems, and they don't always show up on the same timeline, unfortunately. And the goal is not forcing them to sync up through sheer effort. It's building enough flexibility into how intimacy happens. Then when capacity does show up, desire is already waiting for it. And so we also have a thing called hyperfixation. And hyperfixation deserves its own mention because it can be a double-edged pattern in a long-term relationship. So early on, hyperfocus often makes a partner feel like they're the center of the universe. Total attention, total presence. Oh, well, I hear this all the time is when we first got together, the first 2 years were like, oh my God, it was all about us and everything that we were doing. That hyper focus, that phase naturally fades away, which happens for structural neurological reasons and not because the interest is gone. And some partners will interpret that shift as the relationship cooling off. You can't live at that high level 24/7. It's exhausting to your body. So naming or talking about this pattern early, it helps make that completely normal shift in attention being something that your partner can understand and it doesn't get mistaken for a loss of desire. So I would just wanted to go over a few questions that people have asked and see if any of this resonates with you. So one of the questions is it fair to ask my partner to learn all of this, or am I asking too much? It's not too much. Every relationship requires learning your partner's specific operating instructions. This is just a more explicit version of something that every couple already does. It's important to know how your partner operates so that way you can connect with them and be able to be on the same page. Otherwise, that's how a lot of interactions, anger, all that kind of stuff comes about. The other question is, what if I don't know my own sensory or energy patterns well enough to explain them yet? So what I say is to start tracking. You don't need a complete map before you start the conversation. So tell your partner you're still figuring it out, but here's what you've noticed so far. And that's a completely legitimate opening line. And then once you share that, pay attention to your sensory and energy needs and patterns. So that way, when things do come up, you're able to share it. Another question. What if my partner takes all of this personally, no matter how I explain it? Get rid of them. No, I'm just kidding. Totally kidding. Give it time and repetition because maybe their brain may work differently. You never know. And they may not know because there's a lot of people that have gotten autism diagnoses later in life or ADHD, and they don't even know that they have an issue until then. And so give it time and repetition. And a pattern this different from what most people expect takes more than just one conversation to let it fully sink in. Not because your partner is failing to understand it, but because it may contradict assumptions that they had their whole life about how desire is supposed to work. And because this is what you're thinking your entire life, it may take a little time to try to understand yourself or your partner better. And so what does this mean for your partner? And I think what happens is that partners often misread a low initiation pattern as rejection, especially if they don't understand the bandwidth piece. So a direct, low frill communication style common in ADHD and autistic brains often gets misread as maybe bluntness or maybe disinterest when it's actually just them trying to be efficient. And so the fix is asking directly instead of interpreting what they're saying. So you ask them, is this an energy thing or is this a wanting you thing? And that's a very fair, useful question if you're not understanding where they're coming from. And it takes the guesswork out of a pattern that otherwise gets internalized as personal rejection on one side and pressure on the other. So try this. Pick your highest energy window coming up over the next week, let's say. And that means the time of day that your brain is generally more open, has more room left in the tank. So a day that you're not filled with meetings or filled with schedules, just something that you have a little bit more openness. And then protect 15 minutes, just 15 minutes. and take that time for connection, no matter how small that connection ends up looking. It could just be sitting on the couch, holding each other's hands, watching TV. Maybe it's just sitting down, talking, or reading an article together or something that you wanted to, that you found online. Whatever it is, notice how different initiating that feels when you're not trying to bring about energy that you just don't have. And so what I want to talk about real quick is something that I'm totally obsessed with, and that is my community called the Vibe Tribe. And so if you've been listening and thinking, oh my God, all this sounds totally like me, there are people inside of the Vibe Tribe saying the exact same thing. And it's equal parts fun, naughty, educational, and it's the kind of conversations you didn't know that were missing. So I show up personally. There's live sessions, courses, conversations that'll make you laugh, make you think, and make you wonder why you weren't in there sooner. So go to drstacyfriedman.com and click on Vibe Tribe. There is a free week. Come find your people and be there and discuss these things with everybody, because maybe you'll get some more information that you're not going to be getting just through listening to the podcast. So the Vibe Tribe is really helpful. So now I want to talk a little bit about ADHD and desire. We have issues when it comes to ADHD, especially with hyperfocus. And hyperfocus can actually be really incredible for sex. You have total presence, total attention on your partner. Nothing else in the world exists for a while. The catch is getting there because ADHD brains often struggle with the initiation step way more than the once we're doing it step, I'm okay. So the barrier usually isn't interest. It's usually the activation energy that's required to start. And this is where medication actually matters a lot here. So there's stimulant medications such as Adderall or Vyvanse. Those commonly suppress appetite and libido for some people. And it also can affect arousal and delay orgasm. Oh, yippee-ki-yay, isn't that awesome? So we also have non-stimulant options that have different profiles entirely. So if your libido changed noticeably after starting or adjusting some of these ADHD medications, it is worth a direct conversation with your prescriber rather than something to just live with. And the timing matters too, because some people find that intimacy works better in a window where the medication is partially worn off rather than at peak dose. So sometimes taking the medication in the morning versus the evening can make a big difference. And so we also have rejection sensitive dysphoria. And this really deserves specific attention here because it shows up in bedrooms constantly, and almost nobody labels it correctly. It is an intense emotional reaction to perceived rejection or criticism. And that can be very common with people with ADHD, and it can make initiating sex feel genuinely like dangerous to the body because a lukewarm response, a partner being tired, or a joke that comes out wrong can feel like a much bigger reaction or a rejection than it actually was. And so if this is part of your wiring, telling your partner directly, my brain sometimes reacts to a no like it is bigger than it is. And that can take an enormous amount of pressure off of both of you. So you can have the discussion when there is a type of rejection that you perceive. There's also time blindness, and that's another ADHD trait that affects intimacy without anyone noticing why. And that is where you actually lose track of how long since you've connected or intended to initiate and genuinely forgetting. You could sit there and be like, yeah, I think it's been, maybe a week. And then your partner's like, no, it's been at least 4 or 5 weeks. So it's not from lack of caring. It's just how time is processed in your brain. And so a recurring check-in on the calendar, even just like a little low key, putting in an alarm on your calendar to remind you to check in or connect with your partner, that can be very helpful and solves a lot more of this than most people can expect. So now we talk about impulsivity with intimacy, and the ADHD's impulsivity trait. And this cuts both ways in a sex life. It can mean spontaneity that feels like exciting and alive and initiating in playful, unplanned moments, and it keeps the relationship feeling fresh. but it could also mean acting on an urge without checking in first, or losing interest mid-activity when a new thought squirrel captures your attention. And so neither of those, once again, are a character flaw. It's just telling your partner directly that attention might jump around and it isn't about them. And that prevents that pattern from being read as carelessness or boredom. So we have a working memory, and this is the ability to hold information in mind while using it. And it's commonly affected by ADHD, and it matters more for intimacy than people realize. So forgetting a previously stated boundary is not the same as ignoring it, but it can look identical from the outside if nobody understands the mechanism. So written or visual reminders, a note on the mirror, a shared list, something in your wallet, those are not childish, those are accommodations. And that's the same as any other tool that helps make a system work better and helps keep the boundaries tight. And so we also want to talk about the medication timing that I brought up earlier. So you may have a stimulant medication. If that's part of your day, the timing matters for intimacy the same way it matters for focus, let's say at work. And so many people find their libido and sensations are more available a few hours after a dose wears off rather than at the peak concentration, which is hopefully and usually during work. And that's when the body is running a more task-focused, less sensory-focused mode. And this is worth experimenting with deliberately rather than assuming that your current schedule is the only option. But make sure you check with your doctor first, so that way you know that switching the medication times will not be an issue. Now we want to talk about autism and intimacy. And so we have sensory sensitivity, and this is often the biggest factor here, and it's specific to the individual. So light touch might be unbearable for a person, and it may be exactly what the other person needs. So it could be like fabric texture, temperature, sound, lighting, a smell, all of those matter. And a lot of times it can affect sex. A partner's perfume, background noise, scratchy sheets, that can derail arousal just as much as any emotional factor. Predictability matters enormously as well. And a surprise initiation that would read as playful on your side can completely read as distressing to an autistic partner, not because they don't want the intimacy, but because their nervous system was not ready for it and they need to know what's coming. So a signal, a specific phrase, or maybe a consistent pattern of how intimacy starts, that can remove any of the unpredictability without removing spontaneity from the relationship altogether. It just means that the spontaneity happens inside an agreed structure instead of completely out of nowhere. So you could say to them, I would like to be able to kiss you when you're cooking. So when you're cooking, if you get kissed, you may not be like, oh my God, what are you doing to me? So it gives that little boundary, but yet it's also spontaneous. And you know that it's okay that you can do it at that time. And so there may be some meltdowns or shutdowns, and those deserve direct acknowledgement because they can happen around intimacy the same way they can happen anywhere else, and they're not a rejection. So a meltdown or a shutdown after or during intimacy usually means that there is some sensory or emotional load. It hit its capacity, not that something went wrong relationally as a couple. And so planning for recovery time afterward without treating it as some major crisis, that matters more than trying to prevent it directly. Another thing I wanted to mention is called alexithymia. That is difficulty identifying or naming the internal emotional and bodily states. And it makes a question like, what do you want right now? Genuinely hard to answer in the moment, even when desire is there. This is exactly where sometimes a pre-built menu can help enormously, similar to a yes, no, maybe list that I have on my website. I do have the yes, no, maybe list. It's under drstacyfriedman.com, and you get free sex tips. So you click on free sex tips and you'll see all of the free downloads. You can get the yes, no, maybe list right over there. And I talked about this in a previous episode. That doing the identifying work ahead of time when you're not under any type of pressure to produce an answer on the spot can be very, very helpful. And one more thing that is worth addressing is stimming. And that is the repetitive movement or sound that regulates the nervous system. So it could be tapping, it could be like the knees going up and down. It's not separate from sexuality, and it doesn't need to be suppressed to make room for intimacy. But for some autistic people, stimming during or around intimacy is soothing and helpful, not a distraction from it. And so for many autistic people, special interests, the deep, sustained focus on a specific topic, are not separate from sexuality. They can actually enhance it. Bringing a special interest into intimacy, whether through role play, specific sensory elements, or simply that kind of deep focused attention that mirrors how a special interest may feel, that can be a genuine access point to arousal rather than something to hide or suppress in the bedroom. And so autistic communication styles often benefit from scripting. And that is basically having language prepared in advance rather than improvising in the moment. And this applies directly to sex. Pre-written phrases for checking in, for expressing a boundary, or for signaling something that is not working in the moment. That helps remove the pressure of finding the right words on the spot when stress can make spontaneous language even harder than usual. Many autistic people learn early that often unconsciously to camouflage their actual reactions during sex to appear more typically responsive than they actually feel, making sounds because it's expected, showing interest in an activity because a partner seems to want it. This costs the same energy that masking costs anywhere else, and it actively prevents the partner from learning what genuinely works. So unlearning this takes time, and it starts with permission to have an atypical reaction without performing a different one. And this is where that conversation or communication with your partner really, really helps. So a few more sensory specifics, such as some details that are worth naming directly because these can get missed constantly. And it could be something like the weight and texture of blankets or sheets, the temperature of a room, the specific quality of a partner's voice during intimacy, even the rhythm of breathing can be an issue. So we have to pay attention to some of those. And none of these are minor preferences. For a sensory sensitive nervous system, any of these can be wrong. These can be the difference between arousal building and arousal shutting down entirely. So what happens when a partner is in sensory seeking and craves firm pressure, strong sense, and intense stimulation, while the other is sensory avoidant and needs the opposite? This is not a compatibility failure. It is negotiation. And it's the same just as any other mismatch in a relationship. Alternating whose sensory preferences lead on a given night, building a shared vocabulary for adjusting mid-activity, and treating this as a solvable logistics problem instead of just incompatibility. And this can keep both people's needs on the table instead of one person's needs winning by default without anyone deciding that. So that's really, really important. And for many neurodivergent people, co-regulation, which means basically settling the nervous system together through calm, predictable contact before anything sexual begins, this can function as genuine foreplay, even though it doesn't look like traditional foreplay. It could be something as sitting together without any pressure to talk, synchronized breathing, or simply just existing in the same space without any demands that can move dysregulated nervous systems into a state where arousal can be possible. So if you skip straight to sexual touch without this step, that's often why intimacy can stall before it even starts. And so beyond the sensory menu itself, controlling the actual environment matters enormously. Noise canceling headphones during non-sexual closeness, blackout curtains for light control, a designated intimacy space that's consistently set up the same way. These are not excessive accommodations. They're the equivalent of dimming the light for anybody else. You're just doing it in a way that's more comfortable for your partner. And consistency in environment reduces the number of variables that your nervous system has to manage before it could even consider being aroused. And so they are also a state called autistic burnout. And this is the state of extreme exhaustion from prolonged masking or sensory overload. Sometimes that could last for weeks or months. And that takes intimacy off the table almost entirely while it's being active. And this is something that needs to be treated as a temporary depleted state, not a relationship problem to solve by giving it more effort. So if you push for intimacy during these burnout stages, it's going to usually backfire and it can extend the recovery period. And so the more useful way is recognizing the burnout early before it fully sets in and protecting your recovery time the same way you would for any other depletion from anything else that someone might deal with in your relationship. And so here's a concrete tool. You want to build a specific sensory list separate from that general yes, no, maybe list. So you want to talk about texture, pressure, sound, lighting, and smell, each with what works, what doesn't work, and what's depending on the situation. So yes, no, maybe kind of a list. So firm, deep pressure is completely different experience from light touch, and knowing which one you actually want ahead of time removes an enormous amount of that moment to moment guessing that otherwise can derail the way things are going. And so you want to ask your partner about their sensory preferences specifically, instead of assuming that classic romantic setup like candles, soft music, dim lighting, things like that. That can automatically help. And for some people, it does. But for others, that exact setup is sensory overload. So give advance notice before initiating rather than surprising and then learning the difference between I need space right now and I don't want you. Those are two completely different signals that get collapsed into one by partners who have not been able to tell which one is actually working and which one is not. And so what I said before, build your own sensory menu. Take 5 minutes, 3 columns, a yes, a no, and a situational. So include the texture, the pressure, the sound, the lighting. Share it with your partner before you need it in the moment, not during. I also want to take a second and talk to you directly, because if something in today's episode is hitting a nerve and you feel that information in your chest, that is information. It's talking to you. So knowing what's going on and actually changing things are two very different things. And that's where the coaching comes in. I work one-on-one with people who are done just surviving their sex life and are ready to have a sex life that is hot as hell, find their desires, their voice, and their confidence in the bedroom and beyond. I offer a free 30-minute consult, and it is drstacyfriedman.com. Click on the free consultation at the top of the page, and let's talk. Now I want to talk a little bit about depression, anxiety, and medication. Depression affects desire directly through anhedonia, and that is the reduced capacity to feel pleasure across the board, not just sexually. And that means low libido during a depressive episode often is not about your partner, your relationship, or your attraction. It's literally the illness itself blunting your capacity to feel pleasure from anything, including things that you would normally want. So add in fatigue and lowered self-worth, and avoidance becomes the easiest option, even when connection is exactly what would help. And so anhedonia actually deserves more than just a little one sentence mention, because it is frequently misunderstood even by people experiencing it. It is not sadness about sex specifically. It's just a blunted capacity to feel pleasure from anything in general. And that happens with sex, with hobbies, with food, with social connection. And this distinction matters because it means that the fix is not trying harder to feel aroused. It's treating the underlying depression and trusting that pleasure capacity typically will return as the depression lifts, even if it's on the slower side of resolving those symptoms. And depression and anxiety often follow patterns. It could be seasonal shifts, hormonal shifts, stress cycles that are tied to caregiving demands, family, work, whatever it is. And if your desire reliably dips at the same time each year or each month, that's worth tracking and naming rather than being surprised by it every time it happens. And these predictable patterns can be planned around even when they can't be prevented entirely. And so the anxiety keeps your system in threat detection mode. And that mode is biologically impossible to be connected with arousal. Your body cannot fully mobilize for a threat and then relax into pleasure at the same time. Performance anxiety, especially, compounds this. And so you're creating a loop where worrying about how your body will respond, it actively prevents it from responding. You get intrusive thoughts during intimacy. Those are very common with anxiety as well. And they don't mean that you don't want to be there. They just mean your brain's alarm system is misfiring at a fucked up time. So anxiety does not just show up as visible nervousness. And for many people, it shows up as freeze, a flat checked out during intimacy that can look like disinterest, but it's actually the nervous system shutdown response because it's perceiving a threat. And so if you and your partner still seem to check out during intimacy, that's worth treating as a nervous system signal to pause and reconnect, not as a rejection, just as a sign that something is needing to be looked at, not that it's something wrong with the relationship. Now we have generalized anxiety and panic disorder, and these affect intimacy differently and are worth distinguishing between the two. Generalized anxiety tends to show up as like background static, like a mind that won't settle enough to just drop into sensation, even when there's nothing specifically wrong. It's generalized. Panic disorder can introduce sudden, intense physical symptoms, a racing heart, shortness of breath. And these are generally frightening if they happen during intimacy and they get mistaken sometimes for a medical emergency. So knowing what pattern you're dealing with changes what actually helps. There's grounding techniques for generalized anxiety and a clear plan for writing out a panic episode without letting it spiral for panic disorder specifically. So I want to talk a little on anxiety and perfectionism because anxiety often travels alongside perfectionism, and perfectionism does damage to a sex life in ways that are easy to miss because it turns intimacy into a performance to get right instead of an experience to have. And so if part of your anxiety shows up as needing sex to go a specific way to count as successful, then that's worth recognizing before it shows up in the bedroom. Present and connected beats technically perfect every time. It doesn't have to go like this every single time. And so I want to bring in the SSRIs and sexual side effects, and the SSRIs are the medications. And this is enormous and under-disclosed many times, the sexual side effects from SSRIs and SNRIs. These affect a large share of people who take them. Delayed orgasm, inability to orgasm at all, reduced sensation, and reduced desire. These are all so common, well-documented effects, not something you're imagining or doing wrong. Different medications carry different profiles. Bupropion, for example, that has a lower rate of sexual side effects, and sometimes that is added specifically to offset another medication's impact, Wellbutrin. None of this is something to just tolerate silently for years. It is a direct conversation to have with your prescriber, cover the dose timing, alternative medications, or different options. So please don't stop or adjust a psychiatric medication on your own based on sexual side effects. That is a collaborative connection that you need with you and your prescriber, not by yourself, because stopping abruptly carries genuine risk of relapse. And so you're also allowed to advocate specifically and repeatedly for your sexual function as part of your treatment plan. It's not a vanity request. You really need to help with your relationship, with your depression, with your anxiety. It is a quality of life issue that deserves the same weight as any other side effect. And the SSRIs and SNRIs, they get the most attention, but they're not the only medication that actually affects desire. So you have the benzos, often prescribed for anxiety, that can cause sedation and reduced arousal. Antipsychotic medications that are sometimes prescribed for mood stabilization, that can also raise prolactin levels and significantly affect desire and function. The mood stabilizers carry their own separate profile for sexual side effects. And if you're on any combination of these psychiatric medications and your sex life changed, which can be very likely, the specific combination also matters. And that's also a conversation for your prescriber, not a guessing game. Here is the paradox that no one prepares you for. The medication that finally lifts the depression enough to make you want sex again can simultaneously blunt the physical response that makes sex feel good. What the fuck? It's like, why? That is not a contradiction. It's two different systems being affected differently by the same medication. So raising that paradox directly with your prescriber instead of assuming that you have to choose silently between your mental stability and a sex life, that opens up options that you might not know exist. And so what's also important is talk therapy or coaching. And that specifically can help, like for therapy, cognitive behavioral therapy, or acceptance or commitment therapy. That can directly support a sex life that's affected by anxiety or depression, not just the underlying condition in general. And so a therapist who's comfortable discussing sexuality specifically can help you work through the performance anxiety, as well as a coach that specializes, someone like me, with performance anxiety, maybe intrusive thoughts during intimacy, or the grief of a changed sex life, in a way that a prescriber that manages medication alone typically is not positioned to address. So make sure, in addition to changing the medication, if you feel that there's more episodes that require therapy versus just some coaching through, you have those options to look for a therapist or a coach. And so most of what we covered today is manageable with the tools that we've discussed, and an engaged prescriber or therapist or coach can be very helpful. But if depression, anxiety, or burnout has reached a point where daily functioning is significantly impaired, it is a signal to seek higher level of care before focusing on your sex life at all. And so intimacy tools work best as an addition to stable mental health treatment, not a substitute for it. So a couple quick questions and then we'll finish up. Will my sex drive ever go back to how it was before medication? To answer that, sometimes not fully, and sometimes only with adjustments to the medication itself. It is worth pursuing that answer with your prescriber rather than assuming that your current state is permanent, because I've seen it change, and I know me being on it, it has changed depending on the concoction that they come up with. Is it wrong to stay on a medication that affects my sex life if it's the only one that has worked for my mental health? No. Mental health stability is not a lesser priority than a sex life. And for many people, it's the foundation that makes sex life possible at all. And so this is a weighing of priorities that only you and your prescriber can work through together, not a wrong answer that is waiting to be corrected. And so it's just something you need to work on together. And so if you are the partner supporting someone through ongoing depression or anxiety, it's fair to acknowledge that consistently offering connection without much in return is genuinely tiring. And that fatigue doesn't make you a bad partner, and addressing it with a therapist or a coach on your own, or a trusted friend, rather than letting it build into resentment, will protect your relationship more than pushing through in silence does. You may want to build an emotional menu. So similar to the sensory menu from the last segment, an emotional menu is a short, honest list of the kind of connection that you can offer on a low capacity day, whether that's physical touch without expectation, whether it's verbal affirmation, or simply just presence. That helps take the guesswork out of a depressive or anxious stretch. And it also gives a struggling partner different language to offer. That way they can give something genuine instead of defaulting to withdrawal because full intimacy may feel impossible that day. And so what your partner can do is understand that low desire from depression is not a referendum on the relationship, and resist the urge to take the anhedonia personally or the lack of connection personally. Support treatment without applying pressure. to come off the medication or, just for the sake of libido. But that is a decision for the person and their prescriber, not a bargaining chip in a relationship. And make sure you keep offering low pressure connection, even during a depressive stretch, without expecting it to lead anywhere, because the presence still counts even when desire is offline. So that way, when it does come back online, you're there and that connection is still there. And so across ADHD, autism, sensory processing, depression, anxiety, that thorough line is the same one that we opened with. None of this is about the desire that is failing you. It's about the brain running a different set of operating conditions than the ones that most sex advice assumes. So learn your own conditions, communicate them plainly, and build a sex life around the brain that you actually have instead of the one that you think you should have. So if you're on an SSRI or SNRI and haven't specifically raised sexual side effects with your prescriber, write down exactly what's changed for you before your next appointment. Be very specific and make sure that you bring that up to your provider and see how they can help. So my permission slip for this episode is you are allowed to want sex even when your brain works differently than the one sex advice that was written for you and for everybody else. You are allowed to need a signal before intimacy starts instead of a surprise. And you are allowed to blame the medication instead of yourself when your body responds differently than it used to. And you're allowed to have low energy for initiating and still have genuine desire underneath it. Your brain, wired exactly the way it's wired, still deserves pleasure. And that is a wrap on another episode of the Purple Passion Project, where we show up, go deep, and never once pretend that your sex life does not matter. Until next time, stay curious, stay turned on, and never apologize for wanting more. And remember, your sex life does not have an expiration date. Now go live it.
This has been the Purple Passion Project with host Dr. Stacy Friedman. Tune in each week as Dr. Stacy breaks down walls, busting myths, and gives you permission to want more with no shame, no filters, and definitely no small talk. Check in every Monday, 7 p.m. Eastern, on your favorite streaming platforms. We look forward to seeing you next time. Be sure to visit drstacyfriedman.com to learn more.